Thank you very much, and thank you for the invitation, the very appreciated invitation. So my job today is to speak about the figure of the characteristic of sports and exercise physician in the management of obesity. So we all know that all the therapeutic strategies for obesity are effective. So diet is effective, drugs are effective, and also bariatric surgery is very effective on the weight loss and beyond weight loss. But another topic is that we have some side effects, like every therapeutic intervention have, and we have also some untargeted outcome from these therapeutic strategies. And is exactly in this framework that the exercise works, because we know that all the type of weight loss induce sarcopenia and muscle mass loss, and we have reduced aerobic power, and we will see how is important aerobic power also for all-cause mortality prediction, in example. And we have low peripheral oxygen oxidation, so we have a different type of metabolism after weight loss. And then we have some untargeted outcomes that the classical, if you leave me to say in this way, classical therapies don't address, because we have no improving improving in functional capacity, no long-term outcome. We don't know how is the long-term outcome. The quality of life, the mental well-being, not always are addressed from the other therapeutic strategies. But we know that exercise is more than burning calories. We know that exercise is effective in cardiovascular and cardiometabolic outcomes, but also in improving some types of exercise are effective in improving cardiorespiratory fitness and also muscle mass to preserve muscle mass, muscle quality, and muscle function during weight loss. And we also know that physical exercise is effective in the world of quality of life and also in mental well-being and also in managing eating behavior. So the sport doctors is needed, and in this way the path of sports exercise prescription seems plain, because we have the first evaluation, we assess the patient, we assess the cardiovascular screening, and so on. We go through an exercise prescription with specific aims and type, intensity, frequency, and so on. And we go to the follow-up. So we ask the patient, how was with your exercise prescription? So this type of plan, it seems to work. But in the real life, we know that this path is not so planned, because we start from the evaluation, but maybe we found some cardiovascular problem, or maybe we found some therapeutic issue because patients have problem with drugs, or have problem after bariatric surgery, or I don't know, or deal not so good with diet, and so we have some stop. We have to come back to the dietitian or to the obesiologist to manage the therapies, and then we adapt exercise prescription on the basis of what we found on the evaluation, but maybe we can have some problems of setting, because the settings where people can perform exercise maybe are stigmatizing people with obesity. So we have to find the right place and the right solution for this patient. So it's not so easy to go through also the follow-up, and maybe the patient stop and don't come back to the follow-up visit. And we have, and again, to remanage all the plan that we have at the starting point to reset all the evaluation. So the pathway can be different from what we think to be. And to resolve this problem, the sports doctor is not enough, but we need a team, because the lifestyle change is very multidisciplinary. It's a multidisciplinary approach, and all these boxes are not closed boxes, but are interacting boxes. So the sport and exercise doctor can manage, yes, exercise prescription, but have to be aware of the global approach, of the multimodal approach, because maybe can be the point of the starting point of the rethinking all the therapeutic approach. So our strategy is the so-called 5A strategy. So we have to ask, first of all, to the patient. Ask what? First of all, what is his motivation? What is his stage of change? If you want to start an exercise program or not. And we have to check and to ask for barriers, because we can have physiological barriers, individual barriers. Sometimes, very often, people with obesity have fear of movement, because they have pain, because they have osteoarticular problem. They are sedentary, but they are sedentary because every task is heavier for a patient with obesity. So it is not lack of willingness. Is very heavy, the exercise for him. And then he can have external barrier, economic issues and setting issue and stigma issues. So we have to ask of this aspect before to say, oh, you are doing nothing. And then we have to perform function evaluation. We have to assess the starting level of physical activity. If the patient is sedentary, if he started to do something, what the patient likes of physical exercise is not up to the doctor say what do you have to do, but what you like to do in gym or in a pool or I don't know. And then we have to evaluate all the domain of physical performance, because so we have to check for cardiorespiratory fitness and also for strength, for balance, for flexibility. All these are domains of functional capacity. We know that all the last guidelines to define obesity, clinical obesity, what we want to choose, have the functional limitation. But how we check for this functional limitation? Some years ago, we performed a study when we used the classical Edmonton obesity staging system, and then we reclassified these people basing our the functional limitation on cardiopulmonary exercise test. And as you can see, in the stage 2, half of patients were regraded in stage 3, because it is an objective measure of functional capacity. So also in functional evaluation, we have to have a careful way, a careful method. And then we have to go through cardiovascular problem, because obesity is also a cardiovascular disease, so we have to go through the screening, the cardiovascular screening, also with an exercise test when is indicated. So we have to advise. We have to advise specific exercise prescription, written exercise prescription. We have some recommendation, and we have some recommendation for each aims. If we want to preserve muscle mass, we have to prescribe resistance exercise. If we want to improve physical fitness, aerobic fitness, we have to prescribe endurance training, an example. And then we have to manage all the domain of exercise prescription is as a drug. So we have to say how much, what type, when, how many times. We have to, because patients have this question, so we have to answer to this question. And then we have to set and agree with patient with smart goals. So goals that are specific, measurable, not generic, but measurable, because the patient have to know what he can reach and what we cannot reach with that intervention in that moment of his disease. And so these aims are to be achievable, relevant for the patient, and also time-bound. And at the end, we have to assist the patient and evaluate periodically the patient in order to adapt exercise to its problems and to its also preferences and also issues. And what happened in our center? Very rapidly, in our center of management, we have different type of I have 30 seconds to say that we have many type of prescriptors, of doctors, the surgeon, the anesthesiologist, the dietitian, and also the psychologist that can send the patient to us. We do exercise prescription or cardiopulmonary exercise test, and sometimes we receive patients from other specialists, cardiologists, pneumologists, and we make the diagnosis of obesity. So we send the patient to the Center of Obesity Management. And then after our evaluation, sometimes we have to go through other clinical evaluation, and sometimes the patient come back to exercise prescription, some other go to other further evaluation. And then after this prescription, we have an hospital gym to manage the patient at higher risk, because sometimes we have complicated patients that have to be managed in the gym, but the most part of patients go to health gym, general gym, do their exercise at home, or do outdoor activity. A key component of this framework is the kinesiologist, because the kinesiologist can also give a feedback to the doctor and say what went wrong, and to remanage the pathway. So physical exercise is integrated in the management of obesity, because utilized weight loss and improve, counteract side effects and untargeted outcomes. So integrate, please, exercise in the therapeutic pattern of our patient. Thank you.
Thank you very much. I have one question. I see that you're from Italy. Is that something common for patients after bariatric surgery, or patients using GLP-1 medications, to have a part of the multidisciplinary team, your profession as sports doctor? Is that something that is common, or is that in your hospital?
In our hospital, there is a pathway, dedicated pathway. Is not so common, but we shared our experience because we are not so good, more good than others. So we basically interact with the center of the obesity center of management, and we prescribe exercise in every time of the therapeutic pathway of patient with obesity. So before bariatric surgery, after bariatric surgery, during drugs therapy, in patient without any type of therapy for obesity, and sometimes patient comes to us because I have some kilos more than I should, and I want to lose weight, and then we start the therapy. So every type of patient is welcome in our center.
Yes, because I think maybe it's not common. I don't know if maybe the audience can tell us, maybe raise your hands. Do you have a sports doctor in your clinic? Anyone? You have it? Australia? Yes. Well, Australia, of course you would have it, but very active country, very sports.
Yes, and another issue
focused.
is that...
Yes, very good.
Yeah.
So, yeah, I think this is really important, because obviously we know the problems with obesity and medications and bariatric surgery, and your resource is obviously very important. But I think a lot of the things we're going to see today is many of these crucial roles are not common everywhere. And this is what the problem that we see with many integrated health professions. Are there any questions from the audience? Okay.
One question. Sorry about my voice. Is it like a timing when, imagine there's patients that are going to go to surgery, and they're going to go to bariatric surgery? Do you wait some time to exercise before the surgery, or do you prefer to go on the surgery, start the weight loss due to the surgery, and then start with the prescription of exercise?
So the surgical time is about 1 month. But our suggestion is that during this month, you can scratch a ball. You can do stairs, you can move, and after 1 month you can start with an exercise training program, a gradual exercise training program that is different. This is on average. Every patient is different, yeah, of course, but the strategy is to think about muscle mass, particularly before bariatric surgery, because the 50% of muscle mass that a patient loses happens in the first 3 months after bariatric surgery. So it's a crucial point to do what you can do, and not to force the surgical time, but to do something to preserve some muscle mass, or to start to conditionate also muscles, because muscle is not only mass, but is also function, and is also quality of muscle. So maybe we can't increase mass, but we can preserve function, and we can improve quality of muscles.
Thank you. Quick question.
Francesca, thank you. Very nice presentation. I would like to ask you, when do you start training the post-bariatric surgery? How long after? Did you ask that?
Yes.
Okay, but sorry, I didn't hear. So you say 1 month?
On average, the surgical time is 1 month, because patients do their follow-up visit with the surgeon, and then the surgeon say yes, it's all okay, so you can do anything. Yes.
Okay. I'm asking. Sorry, I didn't hear, because your voice was very.
Yeah,
the party. Yesterday we were in the party, I think.
No, just now.
Okay. No, it's just joking. Okay, no, just because we were doing this randomized control trial that we are going to present soon, and we started 1 month right after, and we were having some concerns if that would be like too early to start the strength training. So I think we are okay.
We have to. It depends from how much strength training and how intense is the strength training, and how you manage the training, because the strength training is also to squeeze a ball, or to do stairs,
Exactly.
or to have a
Depends on the
squat is also resistant training. So the important clue is to set intensity and type of exercise on the moment on the condition of the patients.
We have to actually finish because we're like really behind right now. And I have to be a chair. Thank you so much for your interesting presentation. The next person is our clinical psychologist, Eva, which is also in our integrated health committee.
Thank you so much, and I have way too many slides, so let's jump into
let's
it.
try to be.
I don't want to hear the bells. So, this is not working. Oh, it is now. These are my disclosures. And so when I was preparing for this talk, I mean, guidelines have changed considerably throughout the years, and so I was thinking, what is the role that psychology can play in the evolving approach of obesity treatment? And so I have to go back to the Canadian guidelines. And first and foremost, I have to address what I believe has been a major misconception of reading, of the interpretation of this literature. So let me show you there are 3 different pillars in obesity intervention. Bariatric surgery, pharmacotherapy, and psychological intervention. All of these 3 different pillars, they should always support adherence to nutritional dietary plans and increase of physical exercise. So the role of these pillars is to allow the patient to improve their nutritional plan and their physical exercise. So this is a tool to improve lifetime outcomes. Nutrition and physical activity are outcomes of treatment. And why am I saying this? Because also the same guidelines, they establish that success should not be weight-centered, weight-specific. Success should be measured by health, function and improved quality of life. So going back to our pillars, when we think about psychological intervention, we are saying that psychological intervention can be useful simultaneously with other medical interventions to improve adherence to the medical treatment, to improve behavioral adherence and behavioral change during medical treatment. But it can also be used sequentially across different stages of time. And let me tell you what I read in the literature. So when someone, for whatever reason, and I'll come back to the reasons, when a patient stops medical treatment, actually pharmacological therapy, it doesn't mean that the patient is stopping obesity treatment. The patient can progress to bariatric surgery, or they can receive psychological intervention for whatever reason it is. And let me show you what are the reasons that have been suggested in the literature. The reasons for non-persistence of pharmacotherapy has been weight stigma. I know it's small over there, but it's weight stigma, thoughts that the patient is not deserving of therapy, safety concerns, resistance from patient and family, and depression. And psychologists can act on these reasons and improve adherence to pharmacological treatments. However, on other reasons include socioeconomic factors, supply chain issues, and reimbursement problems, along with treatment fatigue, cost and reimbursement issues, and perceived effect of weight or health, and effect size safety concerns from the patients. And in these patients, psychologists will probably not help adhere to this intervention. So sometimes patients will stop medication because of reasons outside of our control. And in this case, psychologists can be a useful tool to provide treatment for patients who stop medical treatment and can sustain in the longer term their outcomes of weight and improved quality of life. So we have a highly heterogeneous population. We need different tools to assess different specific needs in different moments of the patient's life. Each patient has different requirements, and each patient will experience different needs throughout the long time intervention and support that we need to give them. One of the things that we can do as psychologists is to, we know, and the same Canadian guidelines, they support that mental illness can improve obesity and management effects. Not only we should screen for patients who have depression, eating disorders in eating pathology, attention deficit disorder, and other supports that we need, but I would like to highlight that autism spectrum disorders and ADHD are probably important factors that in the future we should look at in order to improve the quality of the intervention we give to the patients, and probably in order to support those who are experienced as the resistant patients or the difficult patients. So we know that there are different phenotypes of patients that require different strategies, intervention strategies. This is a longitudinal study with bariatric surgery patients. As you can see, there are different three phenotypes of patients. Those who have high sustainability in weight, which are the ones in the light gray. And you can see this is a small 8% of patients are the high sustainability patients. The majority of patients are medium or low sustainability patients, which means that at a certain point they will start to decrease or to have poor outcomes, particularly in the long term. And we know that this is associated with poor eating behaviors and more loss of control. So, and this might be true also for pharmacotherapy. And this is one case that has been published in Nature Medicine. And I have to disclose that this is a single case study, but for this single person, they showed that the patient was treated with tirzepatide, and they showed that there was no concerns about food or binge eating, and brain activity was suppressed in the nuclear accumbens during the first weeks of treatment. However, after a period of 5 months, activity in that brain region was detected again, alongside with reports of severe binge eating, suggesting that the effects of tirzepatide on the patient's food preoccupation were temporary, and despite sustaining the tirzepatide at 15 milligrams per week. So this suggests that potentially, and we certainly need more research, but potentially problematic eating behaviors will also appear, just like we've seen after bariatric surgery, after 2 years of bariatric surgery. And we know that psychologists have effective interventions to treat disordered eating behaviors, emotional eating, and loss of control eating. So of course in the future we need to focus on how we can provide and escalate the availability of these interventions. And one of the strategies that we have is the use of other technologies to access the patients in the long distance and in the long term. So as a summary, behavior modification and adherence to medical control, to obesity treatment is one of the things that psychology can have a role in. We can also provide longitudinal support to optimize weight loss and patient-reported outcomes during medical treatment. We can also provide psychological intervention when medical treatment is unavailable or discontinued for any reason. We can also provide longitudinal screening of behavior or psychological risk factors to prevent poor outcomes. And we can work on the identification and treatment of psychological disorders associated with obesity, such as eating disorders, depression, ADHD, autism spectrum disorders, or addictive behaviors. And the development of tailored and precision medicine approaches to identify patients who may require additional psychological support in order to improve or prevent the poor outcomes in the long-term treatment. So, thank you for your attention.
So you did great on time, actually. You said yes. And I have like 3 research ideas from your presentation, so I'm going to write them down after. Are there any questions from the audience before we start? So actually, I'm going to ask a similar question like we asked before. Is it common, because now, you know, so many patients, and I'm actually not going to ask about bariatric surgery, I'm going to ask about the medications, because so many patients are taking them now, and a lot of them are prescribed without a multidisciplinary approach. So again, and you're from Portugal,
Yeah.
which you won, I heard, congratulations. And how common is it for people using these medications in your country to actually see a psychologist or have some kind of intervention?
So we're not talking about bariatric surgery, right? So
Right.
your question is not
Right.
bariatric surgery related.
Because I assume that you...
Yeah. So first of all, let me say, I am a psychologist, but I'm not the kind of psychologist who thinks that everyone needs psychological intervention during medical treatment for obesity. Some patients just do great. They just do their life, they improve their lifestyle. So some patients just do amazing during these treatments. So I don't think it should be a requirement. I do think we should require patients to be screened for problematic behaviors, but not that everyone needs psychological intervention. On the other side, there is a huge concern when patients are under these medications, because the major outcome that is usually assessed is still weight. And we've seen some patients who have reportedly, who have reported very highly restrictive eating behaviors and not having appropriate nutrition intake because they are not being sufficiently supported, and because for the first time in their life, on some occasions, they do feel that they have the control over eating, and they don't need to eat, and there's no what everyone now is calling
maybe
food
teach
noise.
like the primary care doctors what are red flags, like which I'm not sure we do very well today. Like when is a red flag to actually maybe refer a patient, even though it's so many patients, it's really hard to follow them all. But what are the signs that maybe something is wrong and you want to actually look further?
So what are the signs? Are you asking me or just
No,
suggesting
I'm
that
saying
you...
I'm just thinking with you, but
Yeah.
maybe you know them, so you can.
I could give another talk on that topic because I've been very interested on highly restrictive eating behaviors and malnutrition associated with those behaviors during obesity treatment. And one of the reasons that most of these patients, they do not get into a very low BMI. So usually healthcare professionals do not identify those behaviors as very mentally ill. And some of these behaviors will be engaging in very restrictive eating disorders patterns, which end up in being, Francesca was talking about all of the problems who can be associated with poor nutrition. And you, of course, know it better. And I think the colleague who's going to talk later will address those issues as well. So there are signs: afraid of gaining weight, like people being very afraid of gaining weight, restricting their eating behind the nutritional intake they were supposed to do, not responding to satiety hunger cues because they are now fulfilled and they don't know when to start eating. So these would be important things to look at.
Well, thank you very much. We're going to move to the next speaker.
Yes.
Oh, I'm sorry.
No,
Sorry, I didn't see you.
yeah.
I'm sorry.
Sorry, I was just going to quickly say,
Yes.
I think two very big red flags are when people report distress either before eating, during eating, and then a loss of control while they're eating.
Yeah.
I mean, I think...
Yeah, let me just tell you, this is a great point. Yesterday we were talking about, it was one of the patients, she's not in the room I think, but she was talking about how food noise came back and how she's still coping with food noise. As a clinician specialized in treating compulsive behaviors, food noise, it seems like it's a new concept that everybody's talking about, but is a proxy for compulsive eating. So everyone who talks about food noise should be actually addressing and being under treatment for compulsive eating. So these preoccupations with food, they usually mask other problematic eating behaviors that are undergoing. So thank you for highlighting that.
Thank you.
Okay, thank you very much, Eva. It is my pleasure to introduce our next speaker, Julie Parriott from USA. She's a bariatric nutritionist, so.
Okay, well, thank you. I'm so excited to be talking today, and I was planning to do more of a discussion, so we'll see if I can stick to that. So first off, I have nothing to disclose. Secondly, what does a dietitian do? So if we look to clinical practice guidelines, we would like for our bariatric surgery patients, but also the patients who are on medications, to actually have some type of a preoperative or pre-medical medication assessment. And this would be done specifically by a registered dietitian. We also want to see that there's ongoing nutrition assessment, and this care should really be an essential component of not just patient care, but optimal patient care. And then we want to see long-term nutritional monitoring, and ideally greater than 2 years. And again, all of these three things should really be components of a comprehensive patient care. So what I want to kind of do with you is have you think about a patient you might encounter. And I tend to encounter patients that are tired a lot of the time. How many of you have encountered patients that say they're tired? Well, that usually gets discounted, right? We're all tired, right? Don't have a good night's sleep. But with nutrition, we know that dietitians are going to be working with patients on behavior changes for diet, for activity. And in the past, counseling and making those behavior changes was difficult. But I think in the nutrition field, they've done a pretty good job of actually educating and training dietitians to follow and work with patients in that area. But we have a gap. And since we're talking about the future of nutrition, I wanted to bring this out. So there is a gap. And first I'm going to bring this slide up. And it involves micronutrient and micronutrient deficiencies. And so we know just from research that patients tend to come to us with at least one, if not more, nutrient deficiencies. at the time of surgery. And you can assume that if this is a patient who's struggling with weight and usually obese, that this is the same. It's the same type of patient. And so what we have here is the upper level of patients that have been reported, the percentage of these patients with these nutrient deficiencies. And so percentage of iron has been reported in upwards of 40% of patients before they have surgery. And after surgery, guess what? It only gets worse, right? Why would it get better? So it only gets worse. Okay, and then we have other nutrients. We have thiamine. Thiamine is a little bit more critical, but for this talk, I really wanted to focus a little bit more on iron. Because iron is one of those things that when you have a patient and they say they're tired, we can log it on. Okay, maybe not discount it, but log it on. Because it could be that they have a nutrient deficiency that is going to drive their behavior, which means are they going to be able to accomplish all the things that we ask our patients to do, right? Be active, make cognitive changes, make healthy choices with your diet. So if monitoring of these nutrient deficiencies actually drops while the risk rises, then the multidisciplinary team or the MDT needs a clinician whose workflow is really built around this nutrition surveillance. And this is the piece that I seem to see missing. Let me go back. So there is a gap. And in many MDT programs or teams, now I found that in the UK and in Australia or New Zealand, they actually have a great capacity for dietitians to pursue advanced training so that they can actually have what we call prescriptive authority. So they're able to actually order labs, review labs, and then actually treat those deficiencies. But in many programs, in particular mine, the RD can identify the risk, but I have to wait for another clinician to come back, or I have to chase somebody down to actually be able to order additional labs, or even if I base my suspicion or red flag on symptoms, then I have to wait. So there's going to be a delay, right, in the treatment. And so if you have a patient who's already potentially iron deficiency before they have surgery, we're just kind of dragging them along. Same with the medications. If their intake decreases, do you think that that deficiency is going to get better? No, why would it? So again, we're going to encounter really delayed, fragmented follow-up, and maybe even duplication of work, because you might have in your program mid-level or advanced level, whatever you call it, nurse practitioner, physician assistant. But in my program, we're kind of light in that area. And so as a dietitian, we try to bridge the gap. So really, what I see is a future model where an advanced bariatric nutrition specialist, modeled after those countries I mentioned, are really able to practice at the top of our training and scope. So to become a dietitian, we have years of science, chemistry, biochemistry. So we are trained to actually recognize, identify, order protocol-based labs so that everybody feels comfortable. What is the dietitian doing? And we can trend those micronutrient results across time. We tend to have more time with patients than doctors, right? We usually get at least 30 minutes, and you guys, doctors, get maybe, 10, 15, if that? So also, prescribing and adjusting some of these vitamins and minerals as we see patients. And it's not always based on labs. A lot of it is based on interaction, what we perceive, what we see, what we hear. And so it is important to be able to treat patients' issues in a timely manner so that they can also operate at their height, right, of being healthy and doing well. So we also need to escalate urgent findings such as suspected B1 deficiencies, and then we can also provide nuanced counseling on tolerance, adherence, etc. So how does this help the MDT? It would allow surgeons, instead of me chasing down a surgeon, please prescribe this, right? Now they're taking their time to prescribe something. It would allow surgeons to focus on procedures, complications, medical complications, and operative decision-making. Surgeons I work with want to be doing surgery. physicians or APPs. So now they can prioritize metabolic disease, medications, and their broader medical issues. Let us look at the nutrition piece. Psychology, nursing, exercise, professionals, they can stay centered on behavior and functional recovery. So then that allows the nutrition specialist, instead of just being that darn old food policeman or woman, right? We can actually use our education, our training, and really work at the height of our scope. So we could potentially become the lead for deficiency, prevention, detection, and correction. So this practical future workflow, you'd have the pre-op nutrition specialist who completes the assessment, baseline labs, correction, plan, and readiness teaching. And then early post-op and additionally 3, 6, 12 months and multiple surveillance times, we can review symptoms with patients, interpretation, and any supplement changes that need to happen in real time. Because these delays, I just am spending my time chasing. Somebody please prescribe this for this patient. And then there's long-term annual monitoring, which again, we can access these red flags that we encounter. And we can share that within the MDT. We don't keep it within ourselves. We really like to share this. So I wanted to ask you guys, what part of micronutrient monitoring can be safely delegated to an advanced RD, now typically this would be under protocol, in your country? So
You can approach anyone wants to speak. I can walk around with a mic if anyone wants it, but does anyone want to share?
If not, that's okay. I've got some more questions. Okay, and I only have 30 seconds. So which nutrient deficiencies create the most delays in your current service? I'm going to go back to iron real quick. Iron. What do most practitioners, not dietitians, practitioners look at? Hemoglobin. Oh, their hemoglobin's great. They're not iron deficient. No, wrong. They're not anemic. Okay, so you need somebody who can interpret not just labs, but red blood cell indices, etc., right? Do you want to say something?
Julie, just to give you some feedback. Nice reflections. In our case, with Alba, we do have many roles in that sense. We are able to give supplementation. We control that 100%. We can give this information to patients and even recommend because they are.
Can you prescribe?
We do, yeah, because some of them don't need medical prescription, like the typical vitamin and minerals. Well, they buy it over the counter. We also ask for labs. We are able to order labs, with some kind of
so yay,
justification.
Spain.
Of course. Well,
third country now.
Also, one more thing I want to share. We act very transdisciplinary. And I don't know if Alba can add something if she wants, of course, but the surgeon also gives supplementation. We clarify some things about the surgical procedure, and then during the support groups, we continue with this education and management and adherence. We work a lot on adherence on medication. So I think we don't have these tracks as you presented. We are much more transversal, and I think this is key to have these programs. We consider the patient experience is better when they see everyone is aligned. Mm-hmm. We don't contradict each other. We act together, focusing on the person. And this
so that's wonderful. The reality is, though, that there are other countries that you would think in the U.S., right? U.S., hey, you guys are supposed to be doing great. But no, the reality is it's not happening. And, even when I've been the person who's written some of these guidelines, I cannot get my surgeons or physicians unless, let's see, in a couple of different programs, it's taken me 3 years to develop rapport with the surgeon for them to trust me enough to take my recommendation.
Public health. I mean, it's a public hospital, so we are not private practice.
Okay.
So
Yeah, no, I think it's wonderful, and I appreciate hearing that because I didn't know that you guys had that.
Julie, I would like to add that in Argentina we can also prescribe, not prescribe, we also recommend multivitamins without prescription.
We can recommend, there's no problem with recommend. I can tell a patient to go purchase it, but a lot of times it's very expensive, and prescriptions in the US are much less expensive. And so that's why there's this kind of a dichotomy. Yeah. But I know there's other countries too that don't even have dietitians. And so hopefully the people that are then meeting and doing the nutrition, actually this isn't an issue. But I do think that it is a problem in other countries, and it is impacting the patient, the ability for them to be the best that they can be. So that's why I brought this out. This is an area I'm passionate about. So thank you so much.
Thank you.
Well, thank you, Julie. Well, now we're gonna listen to Carmille. It's an honor for me to present to Carmille Asram from Israel. She's a clinical pharmacist. Sorry.
I do have to say about the other presentation we just heard. Oh, you're here. Actually, pharmacists also look at we look at deficiencies, and we also recommend vitamins. So we actually share that with nutritionists. And we do a lot of courses together with nutritionists about this topic. Oh, sorry. Is this working? Okay. So I'm going to present clinical pharmacy today. And what is a clinical pharmacist? Because actually in my country, pharmacy is a bachelor's degree and clinical pharmacy is a graduate degree. And I know places like in the US, all pharmacists are clinical pharmacists, but it's not like that in all countries. And so a clinical pharmacist is a licensed medication expert who works directly with patients and healthcare teams to optimize medication therapy, improve clinical outcomes, and assure the safe, effective, and evidence-based use of medications. So I actually have a clinic. I see patients. They come with their medication list, their labs, their diagnosis, and then I actually write a consultation letter to their primary care doctor. And when I worked in hospitals, I also worked with the surgeons, and we actually changed the medications together. For bariatric patients, they get a discharge letter from me saying which medications do you use. Mostly I see them before surgery, and I change their medications based on what we know might be affected by surgery. When it comes to absorption or just medication they're not supposed to continue, just like some diabetes medication, hypertension medications. So we do a lot of changes in their medications. And so why is the clinical pharmacist important? Because bariatric surgery is the elective surgery with possibly the most profound changes in chronic medications. So not a lot of elective surgeries, patients come with their chronic medication list, and you basically change all their medications or all their formulations. So this is something that you need to have a specific specialty and know the medications, know how things are absorbed. And there's so many different, actually, examples: anti-epileptics, levothyroxine, antibiotics, oncology medications, anticoagulants, psychiatric medications. I think 80% of the patients referred to me have psychiatric meds because we're very worried about what's going to happen after. So basically, any medication, we kind of know that the surgery is going to affect. And just to think about what the importance of this consultation. So this is a study we published not long ago. Basically, we took patients that I consulted on. So there was 165 patients, and that was compared to a large cohort of 38,000 patients. And we looked at their rehospitalization rates after surgery. So I didn't bring the whole study because this is a short presentation, but the patients I saw were actually sicker. They had more medications, more chronic conditions, but we did see a significant decrease in the rehospitalization after surgery for for those who did get consultation versus those who didn't. And a lot of the hospitalizations that were prevented were also related to their medications. Also, there was no mortality in the group of patients I saw compared to the cohort. Other research in this topic showed that preoperative pharmacist consultation prevented potential adverse events and provided strong patient satisfaction. Another one showed that a clinical pharmacist's involvement in discharge medication reconciliation process reduced prescribing of medication classes that are not supposed to be given, and also changes in drug formulation. This is another study we conducted with 210 patients that all got clinical pharmacy consultation, and we actually analyzed what kind of recommendations they received. The most common recommendation was actually medication discontinuation, which was 40%, and also new medications, which was 15%. A lot of other conditions had recommendations like diabetes, hypertension, and what we did is we looked at these patients. So all these patients got consultation in the hospital, and we looked at their medical records in their HMO up to 6 months after discharge. So all they got was a letter, and we wanted to see if actually there was good adherence to the recommendations, and we saw almost a 78% adherence to the clinical pharmacist recommendation. And we think part of it is the fact that the patient got consultation and the letter, and also because there's some kind of gap of knowledge. So a lot of times primary care physicians trust recommendations by specialists. So what kind of questions do we get day to day? And there's so many different ones, like, is a bypass surgery adequate to my patient with epilepsy? Or is the change in my patient's psychiatric condition due to the absorption of their medication after surgery? Like, is this why the patient is depressed after surgery? And we know some patients exhibit it because of their medication. Can my patients take birth control medication? Or what kind of contraception they should use? My patient had breast cancer 3 years ago, and she's taking tamoxifen. Can she actually have like a one anastomosis bypass? My patient is vegan and post-bariatric surgery. Now she wants to be pregnant. Which vitamins should she use? So these are all questions I got, and many more. And you can see this is not simple things. You actually have to think about and research. Actually, there are no guidelines about pharmacotherapy and clinical pharmacy except this one, which I was able to take part of, which is with ESO and not IFSO. So hopefully one day we can do that with IFSO as well. And that's the only one that actually has a section talking about pharmacotherapy use and also clinical pharmacists. We're also trying to do some activities with IFSO and hopefully trying to get the word out about the importance of clinical pharmacists as part of the team. So when is it best to use a clinical pharmacist? Because it's not a resource that everyone is available to have for every patient. So definitely patients with polypharmacy, patients with chronic conditions such as diabetes, hypertension, epilepsy, if they're complex and fragile conditions, before and after bariatric surgery. Like I said, I mostly see patients before surgery to make sure they have good discharge and they know what to do. And also, we have to think about the fact that we're actually trying to do this surgery to save lives, and we don't want our patients to get complications due to their medications. So we have to make sure we manage them well. And then I also made questions for you. So maybe kind of raise your hand if you have a clinical pharmacist as part of your team in your country. Or is that something? Anyone? Where are you from? Austria. Okay. No? US? No? I studied in the US. You don't have one? No. Okay, so you see, that's another profession that is maybe missing. And Where would you think is the most important place to have a clinical pharmacist in your profession or your experience? Where have you ever kind of encountered?
Medication reconciliation. That's what I want.
Do you want me to give you the mic? Medication reconciliation, this is what she said, which everyone knows what medication reconciliation is because it's not actually in every country. It's basically just sitting with a patient and taking all their meds and understanding what they're taking, including vitamins, and then at the end kind of organizing it in a right way, like what should they continue, what should they stop, etc. Did you want to say something? Where are you from? UK. You have 3 pharmacists in your practice? And they're part of the... And are you working in bariatric surgery group? Post-op. Okay. So my hope is really as part of the integrated group health committee that Violeta is our chair, is really trying to kind of show where we need those clinical pharmacists and maybe have better guidelines to what to do with medications, because also it is not very clear what to do with every medication because the research is very, very scarce. There's not a lot of research out there saying what to do with different medications, how to change them. There are many medications that there's nothing out there, and basically you have to use your own kind of pharmacological knowledge to guess based on pharmacokinetics what you think would work. And also there's a big difference between types of surgery. So we don't actually have the same recommendation. If it's a sleeve gastrectomy or a bypass surgery, we might have a totally different recommendation for the medication. Yes.
Hi, thank you for bringing up this topic. I'm hospital pharmacist in the Netherlands.
Hi.
I'm really proud of you being here. But what I do encounter is that we don't have comprehensive international guidelines, but we do have a nationwide actually guidelines which actually pop up whenever you prescribe medication to patient with a bariatric surgery, which we have implemented in Netherlands.
Where again? Are you from again?
Netherlands.
Netherlands.
Yeah. So I was really wondering why we don't have an IFO
I know,
clinical
right?
implementation of these guidelines. But I think the second one is I do get consult. I mean, I'm not really a bariatric pharmacist, but I do have some expertise on this. But then I think a lot of people in the primary care, they don't even know that this patient has undergone a bariatric surgery, let alone that they can actually consult them. So I also wonder how you would actually not do the game on your own, but actually involve the GPs and the
So I can tell you, first of all, we were able, in my country, we were able to, in the Ministry of Health guideline for bariatric surgery, we were able to put in that a clinical pharmacist is part of the team and should be consulted. So that took us a few years, but we did get the Ministry of Health to actually recognize the importance of clinical pharmacists. And after that, basically that kind of opened the door to have more people consult. And in that guideline, we did say when is the best time to consult. And also for the HMOs, because it's national healthcare. So in the HMOs, the insurances, we now have a clinical pharmacist consulting the PCPs or the primary care physicians. But again, it's really not enough. It's like a few, and they only take the really severe patients. But in hospitals, we also have more and more clinical pharmacists consulting, but it's definitely not enough. There's way to go. But we should exchange contact. And by the way, we have a WhatsApp group, IFSO WhatsApp group, the pharmacotherapy WhatsApp group, where we actually bring up articles and questions about medications or any GLPs or anything related. So anyone who is not in the group, sorry, my advertising here. Yes, anyone not in the group, just you can come up after and we'll add you on because, yes. Yes. Wait, Violetta says there's open position available. Anything else you want me to mark it here? Okay. No cars? Anything? Okay. Yes.
So I was just going to say, in the UK, we have the BOMS GP Hub, which Mary and others were involved in creating. So it's a suite of 6 documents to help GPs with post-op follow-up. And one of those is actually around medications. So we did that with Linda's, helped us develop that. Obviously, it's very brief guidance, but it is a little bit there. And the other thing I was going to say, in my practice, it's our clinical pharmacists who are doing the majority of the management of the GLP-1 patients at the moment, as we very slowly start to actually prescribe them for our patients.
Yeah, that's really good to hear. Okay, I'm going to finish now. Thank you very much. You can. Okay. Okay. So for our next presenter, we have Lillian Coe.
No,
Coe.
no.
What?
Lillian, no.
No, it says K-O. How do you say it, Lassie?
If you do a spell check, it becomes K-N-O-W.
K. Oh, there's no N here. From Australia, she's a bariatric surgeon.
Well, thank you very much for having me. I'm from Australia. I'm a bariatric surgeon, and I was very happy to be part of this group. So as far as my talk is concerned, I've got no disclosures, but I'll start off by defining what integrated health means. It's about patient-centered approach. It's about coordinated health services, and it's aimed to provide comprehensive treatment, and in other words, a multidisciplinary team approach. Now, multidisciplinary team approach in the care of the bariatric surgical patient is not new. It was first advocated in the late 1970s at the Iowa meetings of the late Dr. Edward Mason, who is considered as the father of bariatric surgery in the United States. To quote him, he said, "Anti-obesity surgery is behavioral surgery. Outcome is independent of the technical performance of the operation." Now, how wise was that in the 1970s? Now, multidisciplinary treatment is not new in the surgical literature. If you look it up, it's in open heart surgery, breast cancer, rectal problems, and so on. But in bariatric surgery, it has been practiced since the turn of the century, and there's multiple papers that have published on this and the advantages of the MDT. In fact, there's even a book written on this, Weight Loss Surgery, a Multidisciplinary Approach, that was written in 2008. This is one of the best guidelines that I've seen. It is 2019, a little bit old. It's a massive document. It's titled Clinical Practice Guidelines for the Perioperative Nutrition, Metabolic, and Non-Surgical Support of Patients Undergoing Bariatric Surgery. And it's been co-sponsored by several different associations and endorsed by IFSO. Now, this document is massive, but there is unanimous consensus obtained for each of the recommendations, of which there are 85. I won't go through them, so don't worry. But basically, it's based on the fact that bariatric surgery is safe and is effective. The clinical decision should be evidence-based, and a team approach to perioperative care is mandatory, with special attention to nutrition and metabolic issues. It goes on to say that an effective multidisciplinary team starts before the operation or before treatment, around the operation if you're having a surgery, and then in the post-operative period. IFSO, together with the ASMBS, put out some guidelines, some new guidelines for metabolic and bariatric surgery in 2022. And the two associations and federation recognize the complexity of the disease of obesity and recommends that an MDT is to provide a comprehensive risk-benefit analysis for patients who are considering MBS, Why? Because it facilitates the patient's ability to comprehend the lifelong changes after surgery. It helps to assess and manage the patient's modifiable risk factors so that we can help reduce the risk of perioperative complications and removing outcomes. So a consultation with MDT can help patients' modifiable risk factors, and this is endorsed by IFSO and ASMBS. Now you ask, why a multidisciplinary approach? Because obesity affects almost every organ in our human body. And I won't go through them, but at least to say that the journey to weight loss has got many steps. And it's all listed here. I won't go through them each one by one. But I thought in the next few slides, I'll show you in a diagrammatic form how we practice in Australia and what we consider as a multidisciplinary team. Well, we always consider the patient in the center. The rest of us are the integrated health, circling around the patient, putting input to the patient to help their journey. So to start off with, as I said to you, I'm a surgeon, so when I see a patient, they've already had trials of diet, behavioral modifications, or medications. Patient comes and sits in a chair in front of me, and my job is, by the time the patient comes to me, is for consideration of bariatric surgery. So my first job is to tell them what their options are. It's listed on the right. But at the back of my mind, I have to think about how am I going to educate and prepare this patient if they're going to go on this journey. So particularly for surgery, there are potential complications, although they are little. There's the cope psychologically. They need to educate themselves about nutrition, as we discussed earlier with the previous speakers. They do have other illness, so we need to define them and manage them, modify medications, and look for appropriate eating behavior. So the patient in a chair in front of me, I'm just first step, so I'm the first leg of the chair. Patient decides to go to surgery, so that's the second step, the second leg. So prepare the patients before their surgery. They need some counseling. They have some strategies to help with their eating problems. They go on a liver shrinking diet, and they of course need investigations to make sure that when they come to surgery, there's nothing that should go wrong with their general health. Before they get to surgery, we also need to educate them about what to expect in hospital. Not everybody has ever been a patient in a hospital. This might be a first time for them. It's really a daunting experience ahead of them. So we need to educate them about what they expect post-operatively, the ERAPS care, pain relief, how they're going to mobilize, what they're going to eat or drink. And in the post-operative period, they may end up in the intensive care unit for the first 24 hours because of their comorbidities. They might have physicians visiting them because of their diabetes or their high blood pressure that might have played up during surgery. There'll be nurses, dietitian, physiotherapy. They get out of hospital, so that's the third leg, that's the third chair. Well, they're now back in their home environment. They will continue to have care in our clinic. We have bariatric physicians, we have nutritionists, they have lifestyle coaching rather than psychologists. We help them with monitoring their progress, either with apps. We run support group meetings, support either by our bariatric nurses or by phone support. So the care doesn't stop there. Now, just because they've recovered from their surgery and they're starting to lose weight, we can't say, this is the recipe, go and lose weight and see you in whenever. Well, it's about the continuum of care. We educate our patients that they are followed up for life, and we do offer them support. So their post-operative journey is the fourth part, is the leg. So now the chair is stable with 4 legs. And we give them a continuing care, and we provide them with services. Not everyone needs a personal physiotherapist or exercise psychologist, but we offer them all of those care that I talked about. There's dietitians, there's bariatric nurses, and really it's a continuum of care, and we tell them and we emphasize it is really lifelong. So from a mission statement from IFSO, we are to provide a comprehensive approach to the management of patients with adiposity-based chronic diseases. And together, as a member of a progressive healthcare system, we as an integrated team, we should aim to deliver high-quality services to all our patients with education, excellence, and compassion and competence. And I think if we can do that together, we actually will minimize complications and improve outcomes for our patients. Thank you.
Are there any questions from the audience?
Thank you very much. Well, it is a question. Just given your, your long expertise, have you seen a change during all these years in how the multidisciplinary team articulates around the patients? It would be nice to hear about that.
Yeah. So I started bariatric surgery some 30 years ago. And we always believed when we started our clinic that we needed support. So we built our clinic, with all this support. Of course, we didn't start with all this support straight away. We had to build. We started with, the minimum was a dietitian and a physician. Because as surgeons, we don't really want, or we're not equipped to look after all their other illnesses, their diabetes and all that. So we have had a physician with us from the beginning. So a dietitian and a physician was essential. We worked as a team. And then as we went along, we actually recruited the rest of the team that I showed you. Patients love that idea, but we do emphasize that they don't need everybody all at once. It's too daunting. We tell them that on this journey, they may need one or the other, and then as they improve, they might think that, look, I don't need this person's help, but I do need some help with perhaps my lifestyle, strategies. So they can pick and choose along their journey. But they are, know that along this journey, all those services are there for them, and they feel supported. So again, patients may feel all right and disappear and live in their own lives and come back 2 years later because they suddenly realize something's missing. They're starting to gain weight. They come back and we have a discussion, and they'll say, yes, I think I'm eating all the wrong food. So we go off to the nutrition or whatever they need.
Is a multidisciplinary team covered by insurance, or do patients pay out of pocket, or how does that work? I'm interested.
So we work on what we call a Medicare service, and the Medicare service do provide payment for dietitian, for physician. That's why I said we don't have a clinical psychologist, because that's not covered by Medicare, but we do have a physician who looks after the lifestyle care, because the physician has a medical degree. They are covered to cover whatever they need to provide to the patient. So we do kind of modify our team so that we get payment to actually give the best outcomes to our patients.
And Lilia, I have a question. How do you see the future of the multidisciplinary team in the era of the artificial intelligence and telemedicine? How do you see the future of multidisciplinary
I think it will
teams?
grow. We have to work as a team. Surgery is only one part of it. There's medications coming in now, so our physicians and our nurse who are allowed to prescribe have been taking part of that as well. So it's a growing team, I should say.
Thank you.
There's a question. Yes.
Thank you for your presentation. Just a quick question. How is it to build a multidisciplinary team, and how the volume should be of the center, so that you have all those experts who have to be specialized in MBS patients? So you have them full-time there because they have to be there and be specialized. How high a volume of the center of patients should be, and how long can it take, and how easy can it be to build such a team so that you have all those specialized health professionals within reach?
Yeah. So we started as 2 surgeons to start off with, because and we build on it. At the moment, we have 4 surgeons. We actually have our rooms purpose built for the whole team. So we have about 5 consulting rooms. And patients know that when they come and see me, they can also see the dietitian and someone else or someone else. I mean, if they want four appointments, they can have it all at once. So they know it's one location. They don't have to travel, 4 different locations to see 4 different people. So it's in one location.
Okay, thank you very much. Thank you, Lilian. Well, it is my pleasure to introduce Dr. Frederick Lordax, a recognized expert in digital health and healthcare innovation from Spain.
Thank you so much. Well, I'm the weird one here, so I'm the one that shouldn't be here. So I just visited my last patient in 2011. They never called me back, so it's nice. No? It's great for me. And the thing is that I'm also I'm the founder of a company that is working on AI in the medical space here in space. Okay, in Spain. Okay, Spain and also in Belgium. So I wanted to start with something that all of you know, that is when you talk about innovation, there is a big no in the middle. No? So that means that whenever you try to change, to put something new, to add something, there is always a no in all your team, because your team, your providers, your payers, no, that's fine, we have been doing it for centuries like this way, why should we change? It's fine. No innovation, okay? So when everybody talks about innovation, it's so amazing, it's a lie. They are lying to you. But world works, that means that this is the disruption model that Clayton Christensen from Harvard was made famous some time ago. When everybody talks about disruption, that is, it sounds nice, but in the reality it means that this is an absolute change in the way the things were being done since then. About 10 times cheaper, 10 times better, 10 times faster. So, and it's a change for forever. This is what happened, for instance, with the stents, when they started to put stents instead of the open heart surgery. This changed surgery for forever. There is still room for the open surgery in the heart, but everybody is able to perform. Let's say, well, not everybody, but there are a lot of places where stent surgeries can be performed, helping a lot of people to be safe because of that. So it was a change that nobody was expecting, but this has changed the world. And this is maybe what is happening with data. All of you have been talking about data, about the things that you are measuring, but we are living in a world of data. Since now, we only were able to take pictures of this data when the patient came to the medical office, or when came to see you. And the thing is that now maybe is the time when we are able to use all this data in almost real time to take advantage of them, and to have under control all the parameters of most of the parameters of the patients. As an example, do you know that Formula One cars, okay, are taking all the engineers are taking note of about more than 2,000 parameters 3 times per second, okay, in real time. So imagine that you were able, if they can do that in real time with cars, why shouldn't we be taking this data 3 times a day, maybe 10 parameters for all the population? Okay, so the technology is there nowadays, has been there for years, because the Formula One cars have been doing that for the last 20 years, but the time is now to put this on the population, and because we are able to do that. And we have artificial intelligence. You made a smart question about AI. to the doctor about what could happen. Well, the thing, we don't know what could happen, but it's happening, okay? Because, yeah, that's it. So, because from time to time, all the LLMs models, all the generative AI generative models are becoming more and more effective and efficient in different fields. Different fields like mathematics, like language, like reasoning. So, and they are becoming, I don't think that they are smarter, but they are more effective on those tasks, which is amazing. And all of you know, how many of you are using ChatGPT? Thank you. And the one that not using it, what are you using? Anthropic? Claude, that's smart guy. He's a connoisseur, okay? So and this is the thing. All of us are using this technology. All you know about the technology. This never happened before in the civilization. So all we know how it works. So as we know how it works, it's not so easy. It's not so difficult to think about this technology applied on our field nowadays. That is obesity surgery, is obesity treatment. And this is what we try to do in my company, but that's easy to be done. So the real workflow that you have in clinics, in medical centers, globally is more or less the same. So this is the good thing, because you are sharing from different countries the same experiences. The thing is that all you have these blind spots in this workflow with the patient, in this patient journey. This is where, so then there are a lot of places where you could be using AI to be more efficient on your job. It's not the AI would save you. No, no. The AI will make more efficient your work in different spots in your patient journey. And this is about that. AI will not change everything. You will change everything with AI, okay? And this is the thing. But you must be careful because things go fast. Okay, so this is an amazing, well, qualification about who will be affected by the technology that's coming. No, and I just take just to help you to see where are you now in some way. I only took the surgeons and I took endocrinologists about who can be affected more or less. No, so if your job is based in your interaction with the person and is based and something new happens every day, like in surgery in some way, maybe it will be more difficult to be disrupted in some way. If you are a dermatologist or ophthalmologist or a radiologist, that the image is always the same, be careful with your job, okay? And this is about that. So what will happen? I don't know, but if I was here, I would be thinking to move over there, okay? So, and this is just to make you think about that, okay? The other thing is that you come from the States. You know that in the States there are millions of people that, as they aren't able to find a psychologist in an easy way, are using chatbots in a daily basis as their therapist for $15 a month, okay? Character AI. So we're talking about more than 4 million users. 4 million users. Most of them are youngsters. And well, it's why? It's because there are not psychologists in the States. Not really. Are they expensive? Yes, probably. Okay. But the most important thing is that they are not available at 3 a.m. In one Saturday, or in the morning, in the night when you have different ideas and you don't have anybody to talk with, and they go to the chatbot that knows them because they have been talking with it for time and time and time. So then they are more or less trained to understand what happens. They have been working without. This is I especially mentioned the States because FDA has not been very strong with or hard with that, because Mr. Trump, let's say that is very open-minded. Let's say it softly. So he's very open-minded with the idea of AI being used in healthcare. This is not happening in Europe. These guys tried to start. Who's from Italy? They started in Italy. Okay. They started in 2 weeks. They were out of the country because the government said, "What are you doing here?" Where are you? What are you doing here? Ma che cazzo fai qui? No? And as they say, because they have zero evidence, they have nothing backing them in this way. Okay. So then, this is good for Europe, let's say, but this is a reality. But this is coming. So this is not something that will happen one day. No, no. There are millions of users of that. So this is a lesson for us. This should be a lesson for us. That, okay, we are not living in America. This is not America. But it can be America in these terms, okay? The other thing is about evidence. When I was looking for something, I found that this is 2 years. It was 2 years ago, and you mentioned that, the key, one of the key problems that everybody has in the obesity management, especially in bariatric surgery, is the follow-ups. All of you mentioned that, okay? So then the idea here is taking advantage of this, in this preoperative period, in the postoperative period, taking advantage of the AI, taking advantage of the cell phones that all of we have here, because this is the European users of cell phones. Okay, this is real. It was 2 years. Even it's not in time. I mean, this is from 2 years ago, I think. But we are talking about 80%, 90% of users globally in the population. So we can say nobody knows how it works on a smartphone. Okay. This is the thing. So everybody is able, most of the people is able to understand how this works. So the thing is, we have the AI, you have the evidence, you know everything of that. We have the AI that we can make work with all this knowledge that you have been keeping for years. Let's make these tools work with evidence and connected to the systems you have. You have the teams, okay, let's make this work in order to be in contact with the patient 24/7. If something happens and the AI is not able to understand and to give an answer, you will be connected to that. And this is the way to make it grow and make it more popular for everybody. If you have not seen this movie, you should. This is a must, okay? Because it's how a tool can be globally helping the people to feel better, because it's about, as far as I have learned about the people that are suffering obesity, it's more about how you feel and if you are being followed or not than really just numbers. Okay, so it's more about the feelings. So then, and if we are not building these kind of tools, they are using it now, ChatGPT, or whatever they take, okay? So then, this is the thing. We must do something with AI in order to be more efficient, because somebody will do it for us. The times are changing.
Yes.
That's all. And for the next day, why AI can change how surgery is being performed. Thank you.
Thank you very much. Are there any questions from the audience? So I can just say my daughter tells me ChatGPT is much better than me, and he understands her much more.
I'm not sure about that.
So I think it's going to change moms too. She doesn't want to talk to me anymore. It's only ChatGPT now. But thank you very much. This is definitely the future, and I think we can either go with it, we cannot resist it anymore. We just have to learn how to work with it and how to incorporate it in our practices.
And the big thing is that you have the knowledge. Use the knowledge to fit the tool that should be your tool, not others' tool, okay?
Yes, definitely. So thank you everyone for joining our session. Oh, there's a question. Sorry, come back. Sorry.
Tell me about it.
I keep missing people.
Well, thank you for an inspiring presentation. I've been over the past, I think back in 2015, I had my, more than 10 years ago, it's more than that, but I had my first project approved to investigate SMS as a self-monitoring system
Yeah,
to follow up patients after bariatric surgery.
Absolutely.
And we had to come up with a huge amount of short messages that would be sent automatically to the patient when he would report on certain behaviors in a way to improve and optimize adherence to treatment outcomes. So in 10 years, there's a lot of things that changed. All our previous tools are completely obsolete. And we now have a huge opportunity to use these AIs to follow up patients. In a world where human resources are highly limited, to follow up for lifetime patients that will need lifetime support, and there are increasing number of patients that have been supported, I see in AI a great opportunity to follow up these patients, to identify who needs to progress to more intensive care. But most of all, I don't want patients to feel alone. So we should not just leave everything to AI, and we should my concern is how can we find a way of still having some control over AI tools and their use by patients? How can we have AI as a clinical tool instead of just letting be the AI who...
This is interesting. In fact, if you remember the Kaiser Permanente pyramid in some way, you're working with chronic patients, there is a pyramid defined maybe, well, in 2015, I think, more or less, that is about that. So when there are 3 levels of care with chronic patients, there is in the top of the pyramid patients that you must have on the hospital. On the middle, patients that you must do follow-ons, periodical follow-ons. And on the bottom, all the population that more or less starts to be clinically, by numbers, no, but analytic blood test or whatever, in chronic diseases in the starting point, but not really so bad. So this middle space of the Kaiser Permanente pyramid, they started to talk. There are publications working on that instead of having phone checkups or visits from time to time, they started to talk about telemedicine, okay? But the idea now is putting, instead of the telemedicine that is also time-consuming and resource-consuming in terms of time of caregiver, of healthcare professional, is putting AI on that space. But what does it mean? That if things really go wrong in its own way, you go to the top, and this is when the team has to work on that. And the thing here should be organizing, having this in mind. So the AI can't be a finalist tool. Yeah. AI has been in this integrated team that she has been mentioning. So putting it in this team as somebody that you can have at home 24/7. And that if something goes wrong, is able to make you a call in some way, sending you a message or whatever, or being able even to make an appointment for the next day automatically. That is something that AI can do by itself. Okay, so this is the idea that they have about AI in this kind of conditions. So that you have the team, add it to the team. Okay, this is the idea for me.
Okay, thank you. Oh, okay. And anyone who is not in the WhatsApp group, come to me. I'll show you how to join.
Picture, let's go for a picture.